Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. In this module on contraception, I will delve into the comprehensive aspects of contraception. Contraception serves as both an individual clinical tool and a public health service. This masterclass provides an evidence based overview specifically tailored for clinical decision making and system level comprehension of contraception. During my research on this topic, I came across an interesting quote that is highly relevant to this subject. I would like to share it with you. Pregnancy can occur at every conceivable occasion. In a lighter vein, this reel answers the question, which is the best contraceptive? Of course, this is for my baby boomers generation. In our time, it was a child sleeping between parents every night. That was for baby boomers. So then, for the millennials, which is the best method of contraception? It is the smartphone. Globally, the contraceptive burden is substantial. Annually, approximately 80 million unintended pregnancies occur, constituting 38% of all pregnancies. Notably, 20% of these unintended pregnancies result in induced abortions. The occurrence of these pregnancies could have been mitigated through consistent contraceptive use, a phenomenon known as the contraceptive burden. Conceptually, this burden encompasses the confluence of demand for contraception, the imperative to avoid unintended pregnancies, and the resource and healthcare system strain associated with its provision. The following components contribute to the contraceptive burden. Epidemiologic burden. This includes factors such as age structure and fertility desires. Service burden. This encompasses the workforce, supply chain, and commodities required to provide contraceptive services. Individual burden. This refers to the side effects, need for follow-up care, and acceptability of contraceptive methods. High contraceptive burden areas necessitate robust supply chains and task sharing. Common bottlenecks hindering contraceptive use include stockouts, a shortage of trained personnel, and cultural barriers. Women with unmet need are those who desire to prevent or delay childbearing but are not employing any contraceptive method. Among fertile, sexually active women who do not wish to conceive, that is, those with a need for contraception, approximately 20 to 20% globally have an unmet need. In absolute numbers, this corresponds to approximately 160 to 170 million women worldwide who wish to avoid pregnancy but are not using any contraceptive method, as per data published in The Lancet on July 21, 2022. Younger women aged 15 to 25 often exhibit higher unmet need but have the least access to contraception. This disparity is most pronounced in Africa and Asia. Additionally, rural versus urban differences as well as disparities based on wealth and education also exist. There are significant variations in the types of contraceptives utilized across regions and groups. Overall, unmet need has experienced a gradual decline over recent decades, although the pace of progress remains modest. This underscores the fact that gaps in contraceptive use persist despite substantial global advancements in contraceptive technology. It is crucial to emphasize that reducing unmet need necessitates more than merely increasing the availability of contraceptives. Contraception offers significant clinical and public health advantages. Effective contraceptive use mitigates unintended pregnancies and unsafe abortions, thereby reducing maternal mortality and morbidity rates by approximately 30 to 40% globally. It facilitates optimal birth spacing, which is linked to enhanced potential outcomes, including reductions in preterm birth, low birth weight, and neonatal mortality. Beyond downstream individual health outcomes, it also has upstream effects such as contraception empowers women's autonomy, educational attainment, and socio-economic advancement. contributing to gender equity and sustainable development. At the population level, comprehensive contraceptive access is a cornerstone of reproductive rights and an essential strategy for achieving sustainable developmental goals related to health, education, and poverty reduction. In relation to the previous discussion, I would like to pose a question. Could you please identify a health intervention that has the potential to reduce maternal mortality by 30 to 50%? The answer, of course, is contraceptive technology. What distinguishes contraception from family planning? Or are they synonymous? Family planning encompasses contraception, medical termination of pregnancy, and sterilization, all of which are distinct methods of controlling family size. Family planning is a broader concept that utilizes contraception as one of its primary tools to assist individuals in responsibly and safely achieving their reproductive objectives. It encompasses contraception, voluntary decisions regarding the timing, spacing, and number of children, fertility awareness, and services that facilitate these decisions, which includes counseling, access, and safe abortion where legal. Contraception, on the other hand, refers to clinical or behavioral interventions aimed at preventing conception, whether temporary or permanent. In a sense, contraception serves as a tool while family planning represents the pathway and associated services. In the realm of contraception, contemporary women are presented with a plethora of options. The concept of the basket of choice or contraceptive basket serves as a framework within family planning initiatives, facilitating the provision of diverse contraceptive methods, both temporary and permanent, to foster voluntary and informed decision making. Its primary objective is to empower individuals to plan pregnancies safely and effectively while mitigating unmet contraceptive requirements. The contraceptive basket encompasses enhanced autonomy and informed decision making in family planning, decreased rates of unintended pregnancies, and improved continuity of contraceptive use by aligning individual preferences and health needs. In the context of public health policy, the maintenance of an expanded basket of contraceptives is pivotal for universal access to reproductive health services and aligns with global objectives for family planning and women's empowerment. Under India's National Family Planning Program, the contraceptive basket of choice includes the following methods: spacing methods like condoms, male and female, oral contraceptive pills and progesterone only pills, injectable contraceptives, intrauterine contraceptive devices, and centroman, etc. Permanent methods of contraception are female sterilization, that is bilateral tubal ligation, which is the most popular method of contraception in India, and male sterilization, which includes vasectomy and no scalpel vasectomy. What is the cafeteria approach to family planning and contraception? The cafeteria approach to family planning and contraception is a principle that provides individuals or couples with a comprehensive range of contraceptive options. This approach empowers them to make informed choices based on their specific needs, preferences, and health considerations. The cafeteria approach emphasizes client autonomy and informed decision making by presenting a variety of contraceptive methods akin to the selection of food items in a cafeteria. Typically, the methods available under the approach include condoms, oral contraceptives, intrauterine devices, injectable sterilization, both male and female, and occasionally natural or fertility awareness based methods. The cafeteria approach serves as a fundamental pillar of effective and ethical family welfare and reproductive health services. Contraceptive devices are of two types: short acting reversible contraceptives, such as barrier methods, contraceptive pills, etc. They are effective only as long as they are being used. The user has to remember to use them as long as they want prevention of pregnancy. Long-acting reversible contraceptives are methods that provide continuous pregnancy prevention for 3 to 10 years without requiring user intervention. Their set and forget characteristic eliminates compliance dependence efficacy seen in daily or coital methods, making long acting reversible contraceptives particularly valuable for populations at high risk for unintended pregnancy. The rapid return to fertility upon removal combined with minimal contraindications positions long acting reversible contraceptives LARCs as appropriate first line contraceptive options for nulliparous women, postpartum patients, and those with estrogen contraindications. Intrauterine devices, both hormonal and copper based, and subdermal contraceptive implants are good examples of LARCs. Another way to differentiate them is whether they are coitus dependent or coitus independent. Contraceptive devices are of two types. Coitus dependent and coitus independent contraceptives differ primarily in their timing of use relative to sexual intercourse and in the consistency of protection they provide. Coitus dependent contraceptives are methods that must be used at or immediately before each act of sexual intercourse to be effective. Their efficacy depends heavily on correct and consistent use for every coital act. Examples include male and female condoms, diaphragms, cervical caps, spermicidal foams, jellies, or films, and coitus interrupters, that is, withdrawal method. Because they require user action with each sexual encounter, they are associated with higher typical use failure rates, that is 10 to 25%, due to human error or non compliance. Coitus independent contraceptives, on the other hand, provide continuous protection against pregnancy regardless of sexual activity once initiated. Their use does not require any action at the time of intercourse, thus offering greater reliability and convenience. Examples include oral contraceptive pills, that is combined or progestin only pills, injectable contraceptives, subdermal implants, intrauterine devices, copper or hormonal, contraceptive patches, and vaginal rings. These methods typically have lower failure rates, that is less than 1 to up to 9%, because they are not coitus related and depend less on timing of intercourse. In summary, coitus dependent methods are user controlled and provide on demand protection, while coitus independent methods are provider or regimen dependent, offering sustained efficacy through ongoing pharmacologic or mechanical action. Reversible contraceptive methods are those in which fertility resumes after discontinuation of the method. They are suitable for individuals who wish to delay or space pregnancies but desire future family. Examples include hormonal methods, that is, combined oral contraceptives and progestin only pills, injectables, implants, patches, and vaginal ring, intrauterine devices, and barrier or natural methods. Their effectiveness depends on correct use and adherence, but normal ovulation and fertility typically resumes within weeks to months after stopping the method. Irreversible contraceptive methods, also known as permanent methods, are intended for individuals or couples who have completed their family and no longer desire future pregnancies. These involve surgical procedures such as female sterilization, bilateral tubal ligation or tubal occlusion being the commonest, and male sterilization, which includes vasectomy, especially no scalpel vasectomy. These are intermediate surgical procedures which permanently block gamete transport. Although technically challenging and often unsuccessful to reverse, these methods are highly effective, effectiveness of greater than 99%, and require thorough pre-procedure counseling and written informed consent. Perhaps the most crucial yet frequently overlooked component of contraceptive technology is couple counseling. It is a structured, client centered process that entails educating and guiding both partners to make an informed, voluntary decision regarding contraception. This approach emphasizes shared responsibility in family planning and assists couple in selecting method that aligns with their reproductive objectives, medical suitability, lifestyle, and personal values. It must not be coercive. Effective counseling encompasses assessment of family intentions, explanation of available methods, including their effectiveness, side effects, and reversibility, screening for contraindications using medical eligibility criteria, and addressing myths or misconceptions. Involving both partners enhances compliance, satisfaction, and continuation rates while fostering mutual understanding and gender equity in reproductive decision making. If you like this OBGYN content and want to learn more about this topic, please join my affiliate membership program. The details are as follows. This is an exclusive opportunity to deepen your learning experience with my channel membership program. By joining, you will gain access to high quality, in-depth content that I have created specially for you. There are 3 exciting membership levels. First, the basic level. This level provides access to select videos and shorts that will help strengthen your foundational knowledge. It's perfect for those who want a taste of what we offer without committing too much. Second, the priority level. At this level, you will have access to all our theoretical topics. This is ideal for those who want to ensure a strong theoretical understanding and wish to stay updated with the latest advances in obstetrics and gynecology. And finally, the premium level. This is the ultimate package. You will receive everything from the basic and priority level, plus exclusive access to both theoretical and practical topics. This includes my masterclasses on various practical topics and the privilege to watch orations delivered by me in India and abroad. It's a comprehensive learning experience designed to equip you with the knowledge and skills to excel in your career. By joining this membership program, not only will you get access to all this incredible content, but you will also be supporting the channel, allowing me to continue bringing to you the best educational material possible. So, what are you waiting for? Click the join button below and choose the membership level that best suits your learning needs. Thank you so much for your continued support. Together, let's embark on this educational journey, and I will see you on the inside. If you want to know more about this topic or any other topic in obstetrics and gynecology, please refer to my books Modern Gynecology, Modern Obstetrics, and Practical Obstetrics and Gynecology, and other books. For purchase inquiries, contact me on this WhatsApp number. I have also published 2 question answer books which are particularly useful for exam going students. These are Clinical Cases in Obstetrics, 1000 plus questions and answers, and Clinical Cases in Gynecology, 1000 plus questions and answers. These are also available on Amazon.in. You can also follow me on other social media platforms like Facebook and Instagram. The links are given here. If you enjoyed this video, hit the like button, share it with your friends, and also subscribe to my channel for more videos like this. Thank you for watching.